So my name is Alexis Davis. I am the social media manager here at RSDSA. I know you cannot see me this time as we have 3 guests joining us tonight, which is awesome. I'm joined by Jim Roach, Executive Vice President and Director of RSDSA, as well as Dr. Tom Scott, Dr. Jonathan Fass, and CRPS warrior Brandon Pitcairn. I want to take the time to read a little bit about them before we get started. So Dr. Tom Scott is a co-founder of the Scott Integrated Pain Management Center at the University of Pennsylvania. Dr. Jonathan Fass.
I'm not at the University of Pennsylvania. I'm independent. But.
Oh, apologies. I'm sorry about that.
Yeah.
Dr. Jonathan Fass is currently a clinical specialist in the rehabilitation of orthopedic pain conditions at Excel Physical Therapy in Jenkintown, Pennsylvania. And then Brandon Pitcairn is a CRPS warrior who will share his medical journey with Dr. Scott and Dr. Fass and highlight diagnosis, pain management, ketamine, and much more. So do not forget to ask questions so we can answer them at the end of the presentation. Please remember that while the information shared here is helpful, you should consult your physician for any personalized medical advice. So all right, I will hand this over to Dr. Scott to get us started.
All right, thanks so much for that great introduction, Alexis. And I want to thank Jim for arranging this meeting. So my name, for those who missed it, and I'm going to say hi to many of my patients who are on here today on Facebook Live. Thanks for joining us. I'm here with Jonathan Fass, who is an extremely gifted and expert physical therapist with Excel Physical Therapy in Jenkintown, as you just heard, and Brandon Pitcairn, who is one of my first patients when I opened my own practice a little over a year ago. The story we want to tell today really is to focus on Brendan's journey. And he, I think, will have a story that's extremely familiar to a lot of you who have struggled with CRPS. And I know you're going to have a lot of questions about your own CRPS journey. And after we're done, we're going to try to answer those as best we can. The nature of this story, really, I want you to hear Brendan's initial overview of his CRPS struggles, how he was diagnosed, how many specialists he saw. And then Jonathan and I, through Brendan's story, will talk about how I think the success we've had with Brendan was really only possible because Jonathan could do something I couldn't do, and I could do something that Jonathan couldn't do, and that Brendan, even after so many failures, had the confidence and the perseverance to work with us through all the speed bumps to achieve something that was really special. And I hope it's a good story. I hope it's one that gives a lot of you all hope and a direction for how integrated pain care is supposed to work between different disciplines. With that, and Jonathan, I don't know if you want to say anything before Brendan gets started. I'm going to pass it over to first Jonathan and then Brendan.
Well, thank you, everybody. It's a pleasure, honor to be here. I don't really have anything to add to that. I think that's exactly right. I think that both Dr. Scott and I may slip and call him Tom, but forgive me. But I think that it's exactly that for many of you on your journey, I know as a fact there can be frustration with medical support, with rehabilitation support. So we're hoping that we can try to help you through that journey a little bit through Brendan's journey, and that he can share his experience with you and hopefully smooth out that experience, because it is a fact that it is very, besides the challenges that you face, the challenge that you face within the medical and rehabilitation fields is unfortunate, it's unfair, and hopefully we can do a little something about that for you.
All right, your show, Brendan.
Awesome. Well, I guess I'll try to keep it brief and hit all the major points. Yeah, I think it was October of 2016, just sitting on my couch watching TV, and I just had excruciating pain in my leg. And I'm one of those weird cases where I didn't have an inciting incident that I knew of at the time. I had been bitten by a tick, so a lot of people guess maybe Lyme's was sort of the start to my CRPS journey. But I had an orthopedist I loved, and I went in and saw him, and I was having these really weird symptoms, like a lack of blood flow in my leg, and he's like freaking out, ready to give me a knee replacement. So he said, "This is over my head." He set me down. I live outside Philadelphia, and they sent me down to some of the top doctors down there at some really big institutions, and they would bring it to the round table, and they're like, we have no idea what's going on with this guy. So I just went from thing to thing, and my pain started in my knee. And then honestly, it was just the classic, like, oh, here's some opiates, hope you do okay. And they didn't really do anything. And it was just, the pain was getting worse. And it's hard. I bet a lot of you guys have been there, where I just remember being like, I've broken a lot of bones and this hurts exponentially more. You know, I've nothing to compare to this. So over time, I just kept digging away at specialist after specialist. I mean, I have a funny list here. I should read it for you guys. I saw 3 orthopedics. I saw an orthopedic oncologist, a rheumatologist, a hepatologist, 2 functional doctors, 2 Lyme doctors, 3 GI specialists, a GI surgeon, 3 therapists, a neurologist, and 2 pain doctors. And that's before I found Tom and Scott, who are here. So that was a big piece of my journey. The place I was before I was lucky enough to find Tom, and then he led me to Jonathan, was a big university teaching school down in the city. And that's like top class. And I went, and I was just like, I'm at the end of my rope. I mean, I remember being in tears at the office, like, I don't have any more of this in me. You know, I have a wife and kids. I was married, and I just was like, I don't want to end my life, but I don't want to keep doing this because I can't. I physically am exhausted. I can't keep doing this. And by then I'd have my pain spread into my hip, my back, facial pain, and then I'd have flares anywhere in my body. I was bedridden almost 24 hours a day. If I moved, even just laying there, I was like 8s, 9s on the pain scale. If I moved at all, it would go way up, and it would stay up there for a long time. So like a 5-minute car ride, I'd be in pain after that for like 3 hours in bed, just excruciating pain. So I started out with more of like a deep pain. Then I got the classic, like my skin felt like it was on fire and burning, the stabbing, where you just can't even have clothes touch it. And it's the most squirm-worthy, uncomfortable pain. And I know a lot of you have been there. So with all that, I just kept digging away, specialist after
you ever take it to the ER, Brendan?
Pardon me?
I think he was asking about the ER. Did you go
Did
to
Jane ever take you to the ER?
Yeah.
Did you have to go to the emergency room?
Yeah, I did. I wrote it down. I did, I think, 5 trips to the ER total. A couple of times just as the Hail Mary for the pain crisis. I just couldn't take it. You know, I was in tears, and I was like, I'm going to be up all night, and I'm miserable. And I'd walk in the door, and I'd tell them, and, you know, they look at you like you have 3 heads when you say. And at the time, I mean, even early on, I didn't have a diagnosis of CRPS. So I, you know, sounded like a junkie, like, oh, I'm in pain, I need something. And they would just, I remember they one time I went in there, they were slammed, and I was in a bed in the hall, and they hooked me up to Dilaudid, which is like synthetic morphine. And I passed out because they just gave me the full shot, like, here, take your dose, this is what you want, and we'll hook you up and get out of here. And I'm like, what am I supposed to do? And even on it, I could still feel the pain. And I was like, doc, I need something else. And they're like, this is all we have. This is the strongest thing sorry. And I just remember thinking, like, okay, if the ER is a waste of time and the strongest thing they have is a waste of time, what do I have left? So yeah, I definitely, had some tough ER experiences. And anyways, I ultimately, by then I was bedridden, and this one doctor I was seeing knew Tom, and he goes, I threw everything I have at you. I mean, I tried the spinal cord stimulator. I tried injections. I tried nerve blocks. I've tried every pill that they had. I tried, anything from hard opiates to a lot of the like gabapentin, Neurontin, and all of those, and just had almost no luck. I mean, it was just, nothing could scratch my pain. And I just remember, being in tears at his office, and he was like, hey, there's this guy I know, he's starting up a practice, and he's going to do ketamine, and I'm going to pass you to him because we're out of options. We did everything in the book.
Brendan, I have a quick question. Who was the first doctor that diagnosed you with CRPS?
It was a university hospital down in the city, and he was the first guy that saw me. And ironically, I remember being in his office, and my leg was bright red. And he showed there was a resident there, and showed her this, and was like, and then pulled up Google and was like, yeah, see, he could be the Google image for this. But that's that originally, and that was in December of 2017. So it took me 1.5 years to find that diagnosis, because nobody knows. They don't know what they're looking at. They don't know the criteria. So that's how it took me that long to get there.
Thank you.
Anyway,
so you've had really similar to a lot of people. The thing I want to talk about, Brendan, is when we first talked, you know, I want to know what you thought of the plan, you know, when I first mentioned it to you, because you've had a lot of doctors and a lot of physical therapists. And I was, you know, one in a long line of other people you had met. And the plan I discussed in the beginning was not necessarily lots of rainbows and unicorns. And I just want to know how you felt and, you know, what you thought of the plan, and just tell the audience, you know, what our plan was in the beginning, and how it felt hearing kind of my assessment of what the prognosis was and what it would involve to get there.
Yeah, that's a great question. So one of the most memorable things, and I actually have to thank Tom for this, was I went into his office, and he's like, I'm like, cool, ketamine, I've read about it. For whatever reason, I was terrified for ketamine. I'd read online and done my own research, and all these horror stories about people having, you know, hallucinations and other issues and side effects. And I was really like, this is my last resort. But the problem is that at least where I was, nobody was doing it that was close. And for me, riding in the car for an hour was like a death sentence. So it's like I would have to get a hotel and stay. Like it was a big deal. And so when I was really at my wit's end, I went and saw Tom, and I felt a little bit about it because I've heard that you need to find a reputable source. And since a doctor I trusted had known him and recommended him, that helped. But really, patients are great references for that too. But anyways, I went in there, and he's like, yeah, you know, we're going to try this thing, ketamine or whatever. And it was really interesting. One of the things I need to give Tom some credit for is I thought he was a one-trick pony. I thought, oh, he's a ketamine doctor. And I jokingly referred to everybody like that's what it is. No, he's actually any form of pain management. He really gets it and is really good at it, which is great because sometimes you need multi-angled approach, which definitely helped me. But anyways, Tom's like, hey, you know, the ketamine's going to get you to a point where you can start to exist. You know, like I'm not going to take your pain away. You know, he said, if that's what you want, like, we're not going to do it. This is the realistic expectation. But I think we can get you functionality back. And he was great because he's like, well, what do you want? I was like, dude, if I could walk across this room without crutches, I'd hug you. I mean, that's what I wanted. You know, I can live with pain. I can push through some pain, but I just wanted a little piece of my life back. I mean, that's the hardest thing with CRPS. It's like you deal with so much loss. You know, it's not just like loss of functionality, and it's, you know, I can go into, I'm sure a lot of people have it. It's all the emotional stuff too, the loss of friends and an active life and a social life, and it's huge. But I really felt like, you know, okay, if I get a little bit of relief, I'm going to do the work and do this. And Tom was like, yeah, I'm not going to take that pain away with ketamine, but I'm going to try to get it low enough to the point where you can function. So the great news is his next thing was, he's like, I'm not going to help you get out of the bed and get your mobility back. He said, this guy down here, Jonathan, this way, down here, Jonathan is going to do it. He said, all I'm is the means to get you in there. You know, PT is what's going to cure you. And it's really interesting because we were talking about it earlier. I had some horrible PT experiences. So like early on, before I knew it was CRPS, I went in and they're like, you know, rip it, shred it, tear it, it's going to fix you. And I'm like, no. And again, I don't know what I'm talking about. I'm not a doctor. So they're like, do it. And I did it. It just was an excruciating pain. So I was like, yeah, no, I'm not going back there. So I left that practice. And then one of my other pain doctors was like, oh, you should try hydrotherapy and some other form of, you know, desensitization. And originally, I was just doing the hydrotherapy. And I remember she's like, get in the pool and run around. And I'm like, dude, I can't walk. I can't put any weight on my leg. Even sitting in the pool, like without doing anything hurts. And I like that didn't work. So Tom's sitting here like, hey, you know, you need to go to therapy. And I just remember sort of like, I'm sure a lot of patients do, I was like, well, listen to the doctor because I'd like to try this ketamine and see what it's all about. And it was amazing. But I really appreciated Tom was like, you know, part of being a pain doctor, I think we always talk about this as some silly, like, they're going to erase your pain. And I personally, as somebody with CRPS, was like, I would take anything. You know, none of my regular treatments would even give me a fraction of relief. And I was like, I would take anything. You know, that I feel like I could function in everything. And so Tom was like, yeah, I think we got a really good chance of this. I'm not going to promise anything, but I'm feeling really good about this. And this is your best route. This is the only thing that's going to get you out of the couch and everything. And he was right.
I want to talk about, just to shift it over, we started, I'm gonna skip a few steps because we started ketamine and it worked in that it didn't take away all your pain, but some of the pain was better. You had a bit more energy. You were able to sleep through the night. Some of the like extreme burning pain, like with bathing or putting your foot on the ground or having clothes touch your leg, was better. And I said, okay, now it's time. I'm going to send you over to this guy and I want you to work with him and he's going to do his thing. Now, this is the part that I couldn't do. I could kind of get you up, but this is where we kind of, you know, it's like a team sport. I pass the ball. Wait, my camera's reversed. I pass the ball this way over to Jonathan. I said, Jonathan, it's your ball. Brendan has, it's the term we use for something that's really painful that shouldn't be painful. We call it allodynia. You know, I said, Jonathan, we've got the allodynia under a lot better control. He's still got a lot of pain. And from a clinical exam standpoint, when I looked at Brendan's leg after just a year and a half, the atrophy in his thigh muscles and his calf muscles and his gluteal muscles, his what we call the posterior and the anterior chain, was quite profound. He had a lot of work to do. So even if there wasn't pain, his leg couldn't function normally because the muscles were so wasted. Yeah. And so there was a lot of work to do, even in the best case scenario. And I think that's where, Jonathan, I want you to take it over, my friend. What did you think on your initial assessment, and you know, how did you get Brendan to trust you?
I think that the first thing, and Brendan can back me up on that, but you know, unfortunately, when you see enough patients like this, you know, you're not the first therapist they've seen. You know that had they seen someone, you know, good before, you wouldn't be seeing them now. So there's probably some really bad stuff. So I have the benefit of not having to make that CRPS diagnosis. That's a medical diagnosis. Dr. Scott makes that diagnosis. I need to make a movement diagnosis. What is the barrier to Brendan's movement? So with that, I don't have to do a whole lot if I don't need to do a whole lot. If that diagnosis was made and we're going to discuss what's happening, and Brendan was great because he was like, no, do your test. It's okay. But the first he walked in, he sat down. I said, okay, great. I'm not touching you tonight. You're not walking out of here with more pain than you came in with. And, you know, I think that's pretty important because otherwise I'm just like everybody else that doesn't get it, doesn't understand, and doesn't, you know, empathize and try to do my job, which is to make him feel better or not worse. Making someone hurt more is not skilled. So there's really no value in doing that. And whatever information I may or may not derive from that is not valuable if it cost him something to get it. So that's really how we first started. And he gave me that trust, which was fantastic. And I think that the first thing that I recognized in Brendan is Brendan was willing, you know, we had just met each other and he was willing to go there with me. Okay, I'm going to give this a shot. Tell me what you need me to do, you know, and that attitude, even despite the challenges he had had before, I said, okay, we're going to be able to do something special here because there was a trust that was being developed. And that's 99% of the battle right there. So, Brendan, what do you remember about that?
Yeah, I think a good thing to bring up is, you know, I can only imagine people are like, well, yeah, how do you know to trust a PT? One of the things that really stood out to me, yeah, I remember for the eval, he was like, oh, CRPS, I'm not going to touch you. I know that's going to kill you. Like, not going to do any good. Let's not even bother. And I was like, what? Like, awesome. Like, even the, you know, neurologists who diagnosed this want to touch me. And I'm like, great. But so that was huge. One of the things that was great right off the bat, I knew Jonathan knew his stuff, was he taught me these nerve stretches. And there's these different ways, and I'll let him elaborate more on that, that I could stretch my nerves. And I just remember laughing coming in after seeing him a few times, like, I feel better when I leave PT than when I came in. Like, what the heck? Like, something's wrong here. I couldn't believe that, you know, and that I feel like is one of those ways you can start to check, see if you can find a therapist that you like and build that relationship, is that Jonathan got it. And not only did he wasn't full of hot air and he'd prove it by that, but he actually gave me techniques and things that really helped. And it was baby steps. I mean, he was very honest up front about, like, man, it's like, to put things into perspective, I've seen Jonathan for a year and 2 months now. And it wasn't until this past December that I actually was, like, able to put any weight on my foot. So we did a lot of work, but without doing the steps we did before, we did, like, a lot of desensitization therapy. I did some, I guess it's mirror box stuff. And that gave me, like, these small little platforms to get to a place where I could keep going. So it's not an easy road. You know, it's one of those things, you got to want it, and you really got to put the work in, on top of having two amazing guys who know their stuff.
Yeah. So we started off with that. There's, you know, the good part about what we understand now. There's still, of course, a whole lot that is not understood. Why does one person develop this versus another person that doesn't? These sort of things. But there is also a lot of things that we do understand better now, and you got to want to know about this as a practitioner. I think if you're finding yourself, you know, as an orthopedic therapist, if I'm only reading that ortho literature, I'm of no value to you. And if I'm only reading this type of literature, I'm of no value. This is the intersection of experience, and experience has multiple facets and multiple realms. So if I don't feel at least somewhat comfortable or qualified to speak on any of these topics, I'm going to miss something. Then I just hope I get lucky, because I'm not doing enough to help Brendan or something like that. So the good part is that there are things that we know to do now that are evidenced, they work, they help people. That's not the only part of it, but at least there's a place to start. So things like what you were saying, like Brendan, with some of the nerve techniques we might have used, going into graded motor imagery, which I'm sure many people will hopefully be familiar with, and going through that process in rebuilding Brendan's capacity to experience movement and to have that as a normalized sensation, rather than to be processed as something abnormal and therefore threatening, and then have these horrible experiences of pain and whatnot. So after all that stuff, so Brendan, if you could, I'm thinking, like, as we get to, like, that weight bearing, we got to get to the weight bearing thing.
So yeah, it's crazy because I don't even remember, but Jonathan's like, all right, we're going to try a Hail Mary. I'm going to try this, like, it's called, you know, Neuromodulation. It's pretty much stretching of the skin. And he's like, and I'm like, yeah, okay, whatever. And he does it, and it just feels incredible. It's the only time physical, like an actual manual thing, has given me relief instantly like that. And I'm looking at him like, you're a wizard. Like, what is wrong with you? Because literally, it's almost like, if any of you guys have had success with, like, a spinal cord stimulator or anything like that, it's sort of that same feeling. Like, my leg would stop burning, it would go almost cool, and it was like getting a soft massage. But it was crazy because he would be doing it, let's say on my knee, and I would feel it all the way from my toes up into my hip. And then we started to have other cool spot where I was like, wow, I'm feeling that in my shoulder. You know, I was on crutches for 3 years, and I just was like, I never thought of that, you know, like how the things would work together and kind of, you know, were connected, and my nervous system was all messed up. So it was really, really fascinating. But it felt incredible. And it's one of those things, the more we did it, it kept feeling better and better and better. And I just couldn't believe it. I was like, I cannot believe there's something out there that's a manual therapy that is making me feel incredible as I'm walking out of here. No drugs, no nothing. So that was huge. But it's funny, yeah, Jonathan was like, oh yeah, we tried this earlier. And this is where it comes back to the ketamine. Without the ketamine to really desensitize, there's no way I could have tolerated it. I would have said, if you took somebody who had like no relief from their CRPS and you went into skin stretching, it would kill. It's just like, it's not hard, but it's like gently putting your hands on them and pulling it apart, which I'm sure a lot of you are squirming right now just thinking about. I know I did. But it's one of those things that I had just enough help from the ketamine that I could tolerate this. And it was just amazing. So really what ended up happening is I just felt better and better and better. So we did this thing where I would put my foot, just kind of get a measurement of what was going on a scale, like an old analog scale. And I would measure how much weight I could put on and the reps. And it was just amazing because all of a sudden it was like, you know, I was putting, you know, 50 pounds on. And then the next time it came in, it was like 75. And then it was 150. And then my whole body weight, I couldn't believe it. And he was like, I took a step and I like practically burst into tears because I just couldn't believe it. Yeah. And then it was, I took 5 steps and then we would measure it, took 10 steps. So it was really fun. I was thrilled. He went and got he like measured out a distance on the floor. And I got a little counter, and I would count how many times I could walk back and forth. And I would almost double my steps every time. And this is over the course of like weeks. Yeah. And Jonathan probably remembers better the numbers than me, but I couldn't believe it. I mean, I was in excruciating pain, you know, I couldn't walk. I was on crutches all the time. And then literally 2 or 3 weeks later, I was walking. You know, I was so touched because when I got CRPS, I had 1-year-old twins, and one of my twins was walking and one of them wasn't. And I had never walked alongside both my kids, and I just went home and did. And even my dog was like jumping on me because he was freaking out. He's like, he's walking again. That was just incredible. And that was really that skin stretching, but without the ketamine, I wouldn't have gotten there.
Can you describe, Jonathan, there's a lot of questions, just like the technical medical term. I always call it skin stretching because that's what it looks like. Right. The medical term we use is dermato for skin, dermoneuromodulation.
Yeah.
Taking notes,
dermoneuromodulation.
Neuromodulation. Thank you.
Yeah. So a very wonderful and brilliant therapist named Diane Jacobs kind of developed this, and what makes it very interesting and very fairly unique is, so there's a lot of questions about manual therapies. Manual therapies, this is just a very brief, just for everyone to understand. We used to think that it moved joints, or that it somehow corrected these positional faults, these biomechanical boogeymen that exist in the body. And so if I just get you perfectly right, you'll be fine. And that's a lot of the reason why traditional therapies hurt so much and don't work, because that is not how the body works. And that is certainly not something that a manual therapist has the power to do, if that's the case. If there is a joint out of place, you need surgery. You don't need someone pushing on you. So it doesn't work that way, but those techniques do appear to have interface with the nervous system on a very short-term scale. Dermoneuromodulation is meant to be something that is directly, the whole point is, let's see what the nervous system is doing with a very gentle, what is called non-nociceptive. So if anyone is familiar with that term, nociception is a type of nerve that doesn't make pain. It informs of threat. The system then takes that information and determines the appropriate output. Pain may be one of those outputs. It could be stress. It could be many, many other things. So if I have nociception coming in and that is acted upon, I may feel pain from that. So this is meant to be a non-painful stimulant. It's not meant to cause nociception to occur. It's meant to be a non-nociceptive input, novel input, something new. Yeah, kind of like that, right? Kind of like that.
And can I do it for myself?
No, which means that there is almost certainly there's a number of reasons why that could or could not be. And Diane is wonderful, because this is one of those physiological plausibility, but nothing directly to say that it does or does not work. And you have to be really careful about the idea of, oh, well, I know it works because it works for me. It may very well not be. So is it placebo? That's possible. But then we get into what is placebo and as a descending change to the nervous system, et cetera, and all this neuroscience stuff. So it's still doing something, but it may not be something direct because of the stimulation. However, if it is something that's direct, then it may be direct because it is non-threatening interaction between two human beings, two nervous systems. There are basis for this in social grooming of primates and you know, a hug from a loved one, and all of these convey safety, support, attention, and sensitivity to the other person's experience. So all of those things are important. And then the physiological, if there is a physiological effect, it is, again, probably causing information from the system to the largest sensory organ that we have, the skin, in a way that is non-threatening, and therefore may help to inform the system of position, of body shape, size, and information that at this moment is not occurring appropriately or is not being processed appropriately. So that's a big fancy talk for I stretch your skin and wonderful voodoo happens. But as Brandon said, so and then the other question about nerve stretches, yes, that's like your neurodynamics, that's your nerve. You can have stretch, you can have sliding techniques, they're called. The idea of it is that certainly in a condition like CRPS, but in many conditions, the peripheral nerves, the stuff that goes through our body, is literally the eyes and ears of the nervous system. If there is any type of issue going on at that nerve level, it is very likely there's going to be some type of adaptive change, and that adaptive change may be maladaptive, may offer something that is beneficial to the problem of a nerve, but not beneficial to the system in total. So if there's a problem there with the nerve, that's enough, and I'm not receiving appropriate information, I can't act on that appropriate information, that may be one piece of things. And like Tom said, you met one CRPS patient, you've met one CRPS patient. So everyone is different. You cannot say, oh, you have CRPS, I know what to do, and you just start doing it. You have to see what the person in front of you is experiencing. But back to Brendan. So we had gone from about 80 pounds of weight bearing to about 140 pounds of weight bearing. I think, right? It was 140. So that's great. That's more than 50% improvement. He's doing great. And he was sort of plateauing there. We were hanging out there for a while. There's nothing wrong with a plateau for a certain period of time. I always tell Brandon, like, no matter how fast you think you need to go, you know, multiply that by like 3 times. We're going to go 3 times as slowly, because there's no advantage to rush other than, of course, you know, can we make this better? But there sure can be a disadvantage if you go too quickly and excite things. So after a while, we kind of sat there, and that's where we talked about using this skin stretch technique. So the first day we did it, he went from 140 to 150. We used to use a scale that he could weight bear on. Second time he comes in, he goes from 150 was to 170. 170 became 190. 190 became 210, became full body weight. And then Brandon says, I think I could take a step. And he takes 5 steps without crutches. And I think I was messaging Tom like, oh, okay, I'm not going to tell you. You just when you see him, like, I mean, it was amazing. And then 5 steps became 45 feet done 2 rounds, became 90 feet once, became 130, 270. I think we were close to 300-400 after that. Eventually he was doing miles, and we just stopped measuring because it was like, all right, just go and walk. It was shot out of a cannon. It was absolutely, I was afraid once was it when you came back from Disney, Brennan, and you were like, yeah, I went on rides and I did all this stuff. I was so afraid because I hugged him so hard. I was like, oh God, I probably hurt him. Like, I was so excited. I was like, oh my God. Like, it was just beautiful. It was beautiful.
Yeah, it was an unreal. And I'm going to clarify, like, you know, with all of these wonderful interventions, you know, I still, even to this day, I'm doing it. I always say, I feel like I'm 90, 95% of who I was before CRPS, which is absolutely incredible. I mean, that's astounding. You know, and I still have some issues. And so the cool thing was, is as Jonathan was doing this, you know, we'll just call it skin stretching because it's less of a mouthful. Right. I almost didn't realize it, but after I'd done it for a few weeks, like the sensitivity was getting less and less, and the like tingling and the burning pain was getting less and less. So even on the ketamine, it was still there. You know, I was still sitting at, you know, a 6 to an 8 in my pain scale. And again, a 6 is way better than an 8 or whatever I was sitting at most of the time. So the ketamine was helping, but it was amazing because then once we started doing this, that took away a lot of the other symptoms. And it was crazy. One of the craziest thing is I don't know if I call myself a full-bodied CRPS at my worst. I had it pretty bad in my knee, my hip, my back, my face, and it was, you know, I would have flares, and it wasn't constant, but I would have really bad flares everywhere. So I didn't have the chronic pain everywhere, but those other places. But one place that was really fresh, and me and Tom like scrambled to find something, was this facial pain. And it was amazing because even after the skin stretching, he could do the skin stretching on my arm or my leg. And it was cool because it would actually help the pain I would have in my cheek. And the really cool thing is Jonathan was like, wow, this is fascinating. So he actually had me get like an anatomy map and mark when he would do a spot where I would feel it. And it was so cool because I would feel it. Like he could be stretching the skin on my calf and I would feel relief in my hip, in my back, and my face all at the same time. So it's one of these things. I had tried so many things for the horrible migraines. And it's like, for me, it's like a bone pain I had as well as like the surface, the skin pain. But with this, it was amazing because it slowly went away. So it was like this snowball effect. Once my nerves were starting to get reset, they were starting to get used to, I mean, that's the silly way, the layman's terms that I use to describe it. It's like hitting the reset button on the computer. This skin stretching is teaching your nerves. You're reteaching them. You know, they've been stuck with the fire alarm on for so long that that's all they know. That's the only message that they're sending back to your brain. And all of a sudden, it was like they're starting to be like, oh, wait, I'm picking up touch, but it's not pain. It's not triggering. And then it just got better and better and better. So that was incredible. So, yeah, again, you know, I still have symptoms. But it was cool because as we went through this process, I could gradually feel it taper off. So it was like all of a sudden this huge list of symptoms. You know, I could come into a pain doctor and be like, everything hurts. You know, my gut hurts, my head hurts, my whatever hurts, all these issues. It was amazing. And even now, I used to have I would have the weird sweating stuff. A lot of people have. I found I would overheat really easily. Like if it was like mildly warm, I would just be dripping sweat. All my symptoms, and it was a combination of both the ketamine and the skin stretching. It was so incredible because they all shrunk down. So I'm not just talking about functionality. I mean, it's the whole nervous system that goes haywire with CRPS was all being addressed. And it's just amazing how that shrunk down to such a less symptomatic version of myself.
And I think also, Brendan, if you remember this, something that was really important. Tom, I don't remember if I told you that. We did that mapping. We did it on 2 separate occasions. Did I tell you about that? It was really interesting.
It was amazing. I've seen a few patients, and Brendan's was very impressive. It was
it was really interesting. But with Brendan, when we started to figure that out, that he was getting this type of referral somatic type of symptomology, we started to realize, I remember having the conversation with you where it was like, you know, we would work on your shoulder and, oh my God, there's that spot in my leg I haven't been able to get to. And then we realized if you're crutching, you're affecting your shoulder. And it was like, that's why my legs hurt, even though I'm not even using them. And you would have a flare and it would just be frustrating for you because it's like, what else can I do? Because I'm not even putting weight on my leg. And then it turned out, well, that's what it was. And that was a big deal too.
Yeah, that's a great point. And that's what's so hard is there's times where like you feel like your flare comes out of nowhere, you know, and it can. I mean, I'm not saying it can't, but it was amazing because all of a sudden I had this ace up my sleeve. And I think such a hard part of CRPS is just mentally, you know, you're always waiting for that flare, that pain to just hit you. And all of a sudden, working with Jonathan, having this realization, like if I'm using my arms, if I'm crutching a long way, I'm not putting any weight on my leg. And another thing I would do a lot is because my hip hurt, it hurt to sit upright in a chair. So I do a lot of like leaning and slouching and put that weight on my shoulder. So even as I'm resting, I'm giving myself more pain. And it's one of those things I started to pick up on it. And I was like, wait, if I don't, weight bear with my arms at all, I can prevent flares. Are you kidding me? Like, that's unreal. So all of a sudden, this unpredictability of pain that I had it all the time, it was like, wait a second, I can limit a ton of things that are going to trigger this. And that was unreal. I mean, that's psychologically the hardest part of dealing with chronic pain and CRPS. It's just, you're just always on edge, ready to be attacked. So that was a blessing in and of itself. It's the biggest part of CRPS. For me, the toughest thing was a lot of the psychological, the mental, just struggling with it and dealing with it. And I just felt like, oh my goodness, the more relief I got and the more I could learn these little tricks and predictions. One me and Jonathan talk about all the time, and I still have to this day, is weather. If there's not even like, oh, it's raining or it's cold, any change in the temperature, any weird weather, I have pain, and I still do this day. But it's those types of things when you can predict it, it just makes a world of difference because you can prepare for it. And I sit there and I'm not going, oh my gosh, I got through this pain stretch. I'm like, well, it's the weather, and it would help me psychologically get through it. But it's amazing how when you can start to predict, it really does help bring that anxiety down, which in essence is going to help your pain as well.
Jonathan, what you're presenting tonight is new to so many people, and also to me. And how does someone across our nation find a therapist like you who's trained in these techniques?
You can go to, I believe it's Dermoneuromodulating, and I can certainly send you that information if you want to post it. I know Diane, or you can look up Diane Jacobs. That website will come up. There is a listing, although I think I need to get on that. I don't think I'm actually on the listing, but naturally, right? But I know that she does have a listing, and in truth, unfortunately, there, relatively speaking, aren't too many people that practice that. I know many, interestingly enough, end up being massage therapists, practice that a great deal. So sometimes you can find a massage therapist that performs that technique. She has a wonderful Facebook page where they discuss all manner of information research concerning pain and things like that. I think that's what sets that technique apart. Physical therapy and the traditions of manual therapy came out mostly really in the 60s, give or take. We learned it through osteopathic techniques by and large. And so the concepts that informed those techniques at that time have effectively remained. And even though we know much better now, it's still, I hear from students all the time about, oh, does it move a joint or something like that? So what makes that technique wonderful is Diane is very, very wonderfully knowledgeable in, what we understand of pain now, not the something is broken, something is damaged, but rather what is it as an experience and output of a human being. And so that informed her work and the things that she was looking to do. And it's funny, as an aside, when I took that course, I took it because I respect her, I know her, and I said, I want to learn this. And then when I took it, I said, this is hocus pocus. That felt too good. That can't be real. And for a long time, I really didn't use it for too much. And then little by little, I would use it more and more. And certainly for my patients that are dealing with prolonged pain experiences. And then just one day, I didn't normally do it for my regular patients. So if you have an ankle sprain, you have an ankle sprain, let me crack that and do those sort of manual treatments. And one of the therapists in the clinic, we would talk about this technique. So I just decided I'm just going to try it on everybody just to see. And wonderful things happen to normal patients as well. And it was like, oh, I need to probably use this a lot more than I do. And that was, so it's one thing, it's one tool, it's one trick. There are many things, and that's why it's important that a good, competent clinician looks at you look at the individual in front of you, you take, educated, qualified approaches but you have to be willing to say, well, I thought that would work, that didn't, or not sure that this will work, but let's give it a shot, and to go on that journey and experience with that patient. So so for some people, yes, it could be a wonderful, wonderful thing, and exactly as Brendan experienced. And for some people that I have patients that it's not, it's okay, and then we do something else because that's not exactly what they need.
Yeah, thank you.
I wanted to see Brendan just so we could talk. So I don't want the audience to think that we did this and we just came up with this plan and immediately the first thing we tried like instantly worked. We're like, great, no problem. I know some things specifically that I tried, both medications and interventions. I at one point did a nerve block in your face to try to help. That was not terribly effective. I mean, I don't think it made it worse, but like it definitely wasn't like long-term help. I also recommended that you get a spinal cord stimulator, and we want to take us through, that experience. And just as a caveat for the audience here, I see comments and I hear this a lot. Oh, spinal cord stimulators work, or spinal cord stimulators don't work, or gabapentin works, or gabapentin doesn't work, or physical therapy works, or physical therapy doesn't work. One of the things I'd like people to take away from this, and you heard Jonathan say it earlier, I hope you'll hear me say it every time you talk to me, is if you've seen one case of CRPS, you have only seen one case of CRPS. Our importance, I think, as clinicians experienced in CRPS is recognizing not only how variable the presentation and the experience of CRPS can be. Well, there's certain common criteria. They vary a great deal between patients. And similarly, with the treatments that work and don't work, or make it better or worse, it's very hard to know in advance what is going to work for some people and what is not going to work for some people. I've seen people have dramatic results from spinal cord neuromodulation. I have seen people have terrible results from spinal cord neuromodulation. And I've seen a lot of people have it worked for a while and then it wasn't so helpful. So can you talk a little bit, Brendan, about some of the things we tried that didn't work, and then maybe your mindset of, because we did really achieve, I think, some great success, and then let's wrap it up in kind of the next 10 minutes and try to give a chance for questions.
Sure, absolutely. That's a great point. So before I was seeing Tom, I was recommended a spinal cord stimulator. So I got the trial done, which a lot of people will before you get it in. And it helped tremendously. Like I had a lot of relief of like, this is great. So I was like, sign me up, and I got one, and it kind of worked a little bit. But then it sort of wasn't working anymore. And mine was really rare. I had some weird, like the leads got pulled out somehow. They said that like never happened. So in the meantime, I just kept it in and hadn't done anything about it. And I was like, I'm just going to talk to Tom and look at ketamine and go that route. And Tom was like, hey, ketamine's great, but let's look at some other, options. He goes, I used to put these things in patients. And I was like, Tom, are these a moneymaker or whatever? And he's like, no, they really do help patients. And I was like, okay, he doesn't, he has no stake in this, and I'm getting it done at a different doctor. So for him, it's not like he's getting a kickback or anything. I was like, okay, I trust this. So I get my stimulator fixed, and the ketamine I was doing really well on. Like we were starting to make some progress. I was feeling much better. I'm like, this is great. And I go in for surgery, and a lot of people with CRPS have probably read or see that like surgery you get nervous about because there's all these horror stories about it spreading. And I was like, well, I think, the benefits outweigh the risk. And me and Tom really talked about it, looked at it. I was like, all right, let's do this. So I get the surgery, and we turn it on, and my pain came skyrocketing back. It was like the ketamine, with the flick of the switch of that stimulator was gone. I mean, I felt in horrible pain. And me and Tom were like, what do we do? And we were about ready to give up and say, okay, the ketamine just stopped working. Like, that's it. And I was all the way back to square one. And, that was this summer. That wasn't that long ago that I was just like, okay, well, that's it. Back to the bed, back to the crutches. I'm in horrible pain. That's what we're doing. And it was amazing because I'll let Tom tell the story, but he had another patient, and they weirdly had the same thing. And he's like, well, let's turn it off. And again, all of a sudden that ketamine kicked in and started working, and it was great. So that was huge. The other thing I'll just touch on real quick is something Tom recommended, and I think a lot of CRPS patients go through this. I was on so many different medications when I came in to see him that you don't even know what's working and what's not. You know, I was on so many, and the side effects can be gnarly. You know, they can be so nasty. And one of the things I really respected is Tom goes, if something's helping, we'll leave you on it, but let's just start weaning you off everything. Everything, it's poison for your body. If you don't have to take it, I don't want you to take it. And by the time you've seen that many specialists and doctors, you're on things for everything. He was like, let's try that. And that's something I really appreciated too. You know, I was a classic. I did a lot of gabapentin Neurontin, and that's one I'm even on a little bit now, but I went down on it so much. Like I used to nap all day long because I was on such a high dose. So those other steps, I think, are little things you can do to really help yourself. And that's something Tom recommended that was huge. I'm trying to think. I think those were the big ones. You know, by the time I'd seen you, though, I'd done so many things. There wasn't, acupuncture was one that, anyway, I won't go into all of them. There's a ton of things I tried that just didn't work. But that was one of our biggest setbacks. And it's funny because I don't know if other people relate to this, but I just remember like the weather would change and I'd be doing really well at physical therapy. And then I would regress and I would just have this hit in my stomach of like, this is sticking. My progress is gone. This is all I've got. And I think something that's huge is to just keep your chin up. Even as I'm going through all this stuff, I had moments of fear where I was like, yep, we got this far. I took 3 steps back and I'm not getting back there. Or at least it's been months and we haven't made any progress. Or I wasn't this, me and Jonathan would have me doing pretty well. And then I'd plummet and I'd be way down here. And I would just get so down in the dumps, like, wow, I can't get back there. And what I'd really encourage all of you when you're going through your own journeys is like, just keep that in perspective. Like even people like me who, I hate to say success story, but it's amazing. I'm so thrilled with what I've been able to do. That there are pitfalls, there are fallbacks, and just keep that positive attitude. That's really going to get you through the woods.
I think that's a really good point. And Brendan, just so we can wrap up on an optimistic standpoint, let's talk about just kind of your life, like with your kids and with all these setbacks and sticking with a plan now for 1.5 years. I mean, just to wrap it up, 1.5 years ago in January, when you first saw me, you were only ambulating with crutches. You would spend a few minutes on your feet outside with your kids. You're an outdoorsman, you're a sportsman, you're a hunter. You get a lot of satisfaction in life from your fishing and your hunting and your hiking and your camping. And all that was taken away from you. Your marriage was under stress. You were a new father. Sleep wasn't happening. And while you had a strong religious faith giving you a lot of strength, there was a lot of hopelessness there too. And a lot of the medical professionals that let you down. We took you on a journey that you had to walk yourself. And we were a little bit finding the path ourselves. Like, Jonathan and I both have, we're big nerds. We love reading about this stuff, and we love, trying things that are supported by sense and evidence with a sensible risk-benefit calculation. But not all of them worked. And, because we had a team effort, and I think we listened to you, you listened to us, I think the 3 of us accomplished where we found a solution that worked for you.
Yeah.
And why don't you tell us, let's compare your trip to, this was pre-COVID, you go to Disney World every year with your family.
Yeah, we're lucky enough. My dad loves it. We go a lot. And the year before.
Last year's trip versus this year's.
Yeah, so the year before I would rent a scooter, which was just to get around. I really only had enough stamina. I would get out of bed where I was resting. I would hop on the scooter. I'd rush into the parks. I'd do like one, thing where I'm sitting on a slow boat and I'd go around the track, and then I'd be like through the roof. If I was really lucky, I could like have a snack or an ice cream cone with my kids. And then I would hop on the scooter and race back, and I'd be in bed the whole rest of the stay. That was my experience. And it's funny because I was at the time I processed like, I love roller coasters and stuff. And I'd just been like, yep, I'm not ever going to be able to do these again. It just hurts too much. So this year, after I got Jonathan to help with the skin stretching and Tom with the ketamine, I went on a roller coaster again. And I was actually laughing because I didn't even have my stamina to do it. I'm like, man, I feel like an old man. Like I'm getting like dizzy and stuff from doing this, but I just couldn't believe it. I walked you know, all over the place. It was incredible. You know, it's this extremely active place you can be. And all of a sudden I was enjoying it to the fullest. You know, I'd spend all day, every day with my kids. I would, you know, there's certain attractions where you can't take a scooter, and I could walk up them and do whatever I wanted to do. I mean, it's outstanding, the difference. You know, and that's Disney World, and that was my 2 trips. But even just as a father, to be able to do that, and it's like my wife carried the family for years, and to be able to like help her out with, you know, I did vacuuming for the first time in 3 years a few weeks ago, and I did some landscaping, and I've done cleaning, and I play with the kids, and it's just all this stuff from, you know, a lot of you have those loved ones that support you, and it just emotionally felt incredible to give back. But that's the beauty of this whole process and everything. It's just, there is hope, guys. Like I was there. I remember being ready to end my life. I was just like, I don't want to kill myself, but I can't physically endure this anymore. I didn't want to do it. And I remember telling my wife, like, I'm trying my best. I'm so sorry. And just in tears about it, because I knew I just didn't have anything left. And, you know, guys, I was there. I was right there. And then literally the next week, I went in to see Tom, and it changed my life. It's incredible. So thank you.
Welcome back, Brendan.
Thank you.
And just so the other CRPS warriors out there, Brendan, don't think you're just pain-free. Like you still get pain flares.
Yep.
You still have pain, but you're having pain with improved functioning. You're doing all those things that you couldn't do before. And to go back to my initial conversation with you, you know, in January 2019, I think this was our goal. You know, we tried to set a goal. And for all my patients out there, thank you for joining us. It's really great. I see all these names that are familiar, and welcome, and it's great to have you here. The message I want to send for people who are considering ketamine is that and ketamine is just one therapy. It's one among several, but when you're seeing a pain doctor, whether you're talking about ketamine, whether you're talking about gabapentin, low-dose naltrexone, medical marijuana, or any of the other, you know, standard medications, the medications are just one part of this. It's the lifestyle change. And we're not talking at all about the cognitive behavioral therapy approach, which is a whole other therapeutic approach to CRPS that's absolutely essential that we are not even touching on in this conversation. And then you have this great collaboration with Jonathan, who tried a number of things. I mean, we talked a lot about dermoneuromodulation, or as we call it, skin stretching. But you know, that was one among several different things that was successful. Hopefully we can share with you all either a demonstration or a link to some of Dr. Diane Jacobs' work and what she does and how she does it. But if you Google Diane Jacobs and dermoneuromodulation, you can see videos of her doing it. And it's actually an incredibly simple technique. I think it does have to be done by someone else. You can't do it on yourself.
Yeah, you can't do it.
But you know, Jonathan can speak for it. I think it's something that can be taught if you want to learn it. And
yeah, Jonathan actually taught my wife how to do it, because again, I tried it for myself, and it does a teeny bit, but you can't really feel it. Jonathan, my wife came in and learned how to do it. And so when I'm like away, or like if I'm going to go on vacation, she learned how to do it. And there's actually, she has a great book about it, so that you can even look up in the book and kind of get an idea of where to do it. So if you can't find a physical therapist who can do this, and you feel like you could tolerate it, there are ways to do it. So, you know, don't get discouraged.
Yeah. What's wonderful about that technique, and it's exactly what Tom was saying. Some people it will be great. For some people it will be, I don't feel like anything. And for some people, I've had people that say, oh, that's too sensitive. Brandon was in the very beginning. So it's not a panacea, but it is a possibility, right? The technique is deceptively simple, and it's not magic tricks. It's not, you know, you have to go through some type of incredible course. You can learn those techniques. And I think what's important here is, you know, unfortunately, again, it goes back to that idea of, if you're not finding practitioners that are knowledgeable and understanding of your condition, then sometimes that, you know, unfortunately, that advocacy for yourself, and even finding someone that's willing to try, they just don't know enough. If the two of you go through that journey together, sometimes that's a beautiful thing too. So, you know, saying, hey, you know, was watching this thing and they mentioned this DNM. Can you look it up for me? And can we try something like that? And why not? It's that. So, it's not too difficult. And if that is an opportunity, and if not, there are other things and other sources and other ways that you can go about the problem.
I think that's a great point. For you CRPS warriors out there, keep trying. I think the advice I would give is exactly to echo what Jonathan said, is if the power of the internet is these amazing Facebook Live things where we can share 3 different perspectives on the same problem. And this is just one problem in the myriads of experiences in CRPS. I think Jonathan's comment to ask your clinician, hey, do you know about this? Like ask your doctor, hey, do you know about low dose naltrexone? Do you know about ketamine? And some of the things about doctors, just from our perspective, like we can only do kind of what we can do. Mm-hmm. And the thing that's frustrating as a doctor is sometimes what you can do is only what your institution will let you do. And a lot of times your institution won't let you do ketamine. Your electronic order set has no means of ordering low dose naltrexone because it's not in the formulary. It's a compounded drug. You just can't freaking do it. And, maybe it takes hours just to figure it out. But if you ask your clinician, hey, do you know about this? Here's the phone number. You do a little work on your own. Can you look into this? A lot of times clinicians really who want to help you will try to figure it out. And I've learned so much from my patients who have come to me with this stuff and be like, gosh, I never knew about this. This is really cool. We're going to start doing this more with other people. And so I want to invite all of you and all of my patients as well. If you find something that we haven't tried or we don't know about it, please bring it to me. And that's how we get better. We all learn together. And that's how we beat CRPS.
So Tom, thank you, John. Thank you, Brendan. Thank you, Tom. So why don't we take some questions? And from Alexis, why don't you join us again?
All right, I am back. Unfortunately, you all will not be able to see me today, but I do have a few questions that I've been collecting here in the background. So I know there have been a good number of questions about dermoneuromodulation. And I guess there was one question that came through about how long and how often is that process? Mm-hmm. I know it will vary, but I guess just,
It will, and it depends on, it depends on the individual. The whole point of that is patience. This is not a quick, I went to the chiropractor, I cracked this and I cracked that. There are techniques for that, not for DNM. DNM is meant to be a slow, gentle, and patient process. What I love about it, and Brendan and I have talked about it, and I'll give an example. It feels, there's a feeling that you get with it that is unlike any other manual treatment that you may have experienced. And I feel that too. That's what's really wonderful about it. Brendan and I I work with him. He tells me what to do and I just follow what he's telling me to do. So I will have a sensation here. It feels good. It feels tight to this direction. I won't go in that direction. There is a basis of the directionality of the subdermal nerve structure, but that's also variable to individuals. So you kind of use that as a basis, but eventually you just sort of feel what's happening, and then you just stay and you let that information accumulate. You allow the nervous system to process it. For some people, it's just a small area that you work, and that does the job. And for Brendan, we will go head to toe because he has responsiveness everywhere. So why not? And we'll just talk about, is this good? Should I go more? Yeah, get a little bit more down by the ankle. Great. And we just do that. And it's wonderful for him, but everyone is a little bit different. So it really is a trial and error. And I will normally, as the therapist, if it's working in an area, I will try a few different, let me work on your shoulder. Tell me if you feel anything. Every once in a while someone does. Most people won't. Great. We covered that. And let's go back to this other area. So what's wonderful about the technique is that it is an assessment as well as a treatment, because as I'm doing that, Brendan's giving me feedback, the patient is giving me feedback, and I'm learning about that nervous system and what that presentation is and where some other pieces of the puzzle might fit in. So it's a very rewarding experience, but everyone's different.
Yeah, a few quick details I'd add that just were coming to me is one thing that was interesting is as I'm getting the skin stretching, I'll actually feel like the nerves are like, oh, here comes the pain. And it would go, I would have a small pain increase and then it would plateau. And then all of a sudden it would just plummet and be way better than when he started. So it sort of has this weird sensation where my brain kicks in. It's like, whoa, don't touch that. And it starts, the pain starts to go up. And it's like right before it starts to get painful, it would kind of like level off, and then it would feel incredible. And it's interesting because when we first started doing it, we'd probably only do it for maybe 20 or 30 minutes. And now I'll go see him, and there's times we've done it for like an hour and a half, and he'll just work his way around. So it's definitely something you sort of get into, and it'll help more and more as you do it. I'm blanking on my other point, so I apologize. Anyways, if I think of it, I'll come back to it. But yeah, I guess, or that was it. And we do it. You know, what worked for me was I go in twice a week. So twice a week I go in, I get this done, and it was great because that was long enough to carry me to the next one. And it was great because after, if there was like a 4-day stretch or a 5-day stretch, I didn't have it, I'd start to feel like stiff and pain and sensitivity. And either I could do it. And the other funny thing is it doesn't work with a flare. For some reason, if I'm having a really bad flare, it's too late. You know, you just got to ride it out, unfortunately. And once it calms down a little bit, I think your system just gets overloaded. It's just too much going on with your nerves. Once my flare calmed down, then I could do it, and then it would really help take the edge off. So it's great because I was like, okay, well, I'm going to go do something fun today, something active, do some skin stretching before that would help me have longer duration during the activity. And then when I got home and it calmed down a little bit, I could do it again to help me recover. So it's kind of a great, and there's not like too much of it. Your body's like, okay, that's too much touching. That pain that I felt is just kind of staying there, and I'm not having that relief. Then you know you're done, and you take a break.
Jonathan, Diane Jacobs has joined our chat.
Yes, yeah. Hi, Diane.
Hi, Diane.
Hi, thank you.
Diane, I saw just this is one of her favorites. She'll I'm sure she'll be in the chat there, but she said, turn nociception to yes-eception. I love that. That's that little nerd humor that Tom was talking about there.
We have a question from Eva who is asking, she's going to, ortho doctor and pain specialist, but at what point do you think she and other warriors should see a neurologist? Is that like the first step in trying to get help, or, where should that fall in the process?
So repeat that question one more time for me, Alexis.
Oh, sorry about that. So Eva is asking, at what point do you think CRPS warriors should see a neurologist, and how can that also help, with everything going on?
I think that, a good neurologist is worth their weight in gold, and it's not whether it's a neurologist or a interventional pain specialist or an internist. I think the question is within an individual. Do they have the curiosity and the interest to work with something that is complex and difficult to treat? I think, the struggle that many healthcare professionals have is there's a huge amount of institutional pressure to put people into boxes and make a lot of, square pegs fit into round holes and say, this is what we do for ankle pain. This is what we do for weakness in the knee. This is what we do for that. And then you kind of just go boom, 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 boom. And if you get into that pigeonholing approach, whether you're a neurologist or whether you're an anesthesiologist or an internist or a rheumatologist or a physical therapist or a psychologist, and there's a huge amount of pressure to do that, because that's how you see a lot of patients and make a lot of money. It doesn't work that well for CRPS. So a skilled neurologist is valuable if they have experience in CRPS and understand how to do adequate assessment, get the diagnosis. And getting the diagnosis is sometimes tricky, because there's pesky little detail in CRPS diagnosis that you have to exclude other causes. And, there's a lot of things. There's a lot of things you got to exclude. And sometimes it's pretty clear, but a lot of times it takes time. And luckily for me, at least, by the time a lot of patients get to me, they've actually had most of the diagnostic workup that's necessary, but sometimes they haven't.
What's funny about that, Tom, is I remember seeing the neurologist, and he was like, yeah, I think maybe you have CRPS. I was like, great. He thinks I have it. I'm like, can you tell my pain doctor so that he can treat me for it? And the neurologist goes, no, pain doctors see it way more than I do. They're the one who'd be better at diagnosing you. So I would kind of answer that question myself personally. Neurologists, if that's going to help get you the help that you need, and you think that they kind of have the leverage to help convince people, but it doesn't, you don't have to see a neurologist. And I just thought that was so funny. I wanted to do that. Like, oh, I'm going to see a neurologist. They'll diagnose me. Then I've got the, the label, and I can throw that around when I go see a doctor's office. And the neurologist was like, no, dude, I'm not advocating for you. Go talk to your pain doctor. Like, they're the one who's really going to, diagnose it and know what to do with it. So anyways, that was my experience, for whatever it's worth.
Yeah, I mean, in Philadelphia here, we had Robert Schwartzman, who really started the ketamine revolution. He was kind of the high priest of it. And of course, he was a neurologist. And if you saw Robert Schwartzman, he'd be the man. I mean, that's the guy you see. And, Enrique Aradias, who, was another neurologist, also very knowledgeable in CRPS. But then in New Jersey, right across the river from us, you have Phil Getson, who's an outstanding CRPS physician, extremely knowledgeable. I could not have more respect for anybody professional. And he's a family medicine physician.
Yeah.
So, I think you just have to find someone who's interested in working with this kind of problem. And it's less about the specialty per se, and it's more about the specialist individual.
I agree.
Yeah, I think also to jump in just from, I'm sure many of you have the same experience, and certainly many of my patients too. It's a matter of having someone that you trust and someone that can advocate, and regardless of their specialty. So if you have someone that's in your corner when you're fighting off, so to speak, oh, there's nothing wrong with you. Oh, it's just this. Oh, it's just that, and not taking you or your condition seriously enough. You need someone that you can fall back on, and they can help to advocate for you until you do find that person that understands you, understands what you're going through, and can try to help you on that journey to something else. So regardless, so Tom, I probably drive him nuts, because I send half of my patients to him. It's like, oh yeah, John said to see you and my shoulder hurts. And because if I don't trust anyone else, I'm sending them to Tom. And Tom, at least, okay, please, man, just send this person in the right place, because I know I can trust Tom. And it's that sort of thing. It works for us as well. And that feeling of support and someone in a medical field that it's understanding of who you are and can get you through those hoops and on that journey is so valuable. So.
And sadly, Dr. Scott has a waiting list.
Yeah, I'm sure I see some comments from people who I know you or a relative is on my waiting list, and I want to just tell you all how sorry I am. I'm trying my best to get you in as fast as I can, and I'm closing my office for the next 2 days because there was some looting less than a quarter mile away from my office, where a shopping center was just annihilated. And we're going to keep working hard to get everyone in as fast as we can. And between the twin crises of coronavirus and the civil unrest and the protests, these are exciting times. Yeah. And you may have noticed me move. We also had a tornado warning. Yeah. I don't know how the rest of you guys are doing, but my wife sent me a text like, you need to go to the basement, because I looked outside just in case it was not apocalyptic enough. I had to in the basement. But I really am grateful for the chance to be here. I really am excited to work with more of you all in the CRPS community. It's a pleasure to be a part of this group. And Jim, thank you for making these arrangements. It's a pleasure.
It's great. And I know we'll be in constant contact in the next few days. And gentlemen, be safe. And Alexis, thank you so much. We're going to be in 2 weeks, we're going to have a really special guest, Stephen Brule, who's a chairman of our scientific advisory committee. And he is the doctor with Norm Harden, who validated the Budapest criteria, and he is just so knowledgeable about CRPS and one of the more brilliant men on this planet. So I really hope that you'll join us for that. We're really going to get into a lot of the mystery of CRPS.
Yes, definitely. And we have that Facebook Live. It's going to be Wednesday, June 17th at 7 Eastern. So, of course, we will make a Facebook event for that, send it out via email, and also add it to our website. But before we end, I do have a couple of quick announcements. As always, we will have this video pinned to the top of our Facebook timeline for easy access this week if you want to rewatch it. And we will also add it to our YouTube channel. If you have any questions for us, if you need a support group, if you're looking for a new physician, or if you want to tell your story on our blog, please send us an email at info@rsds.org. And finally, we still have face masks available if you are looking to purchase a few. You can simply head to the RSDSA website and click the brand new store button, and you will be able to order a mask, and we are ordering more. We have more on the way. I know earlier today we had about 20 left in stock, but we do have more on the way. So you can definitely order a face mask.
Our baseball cap.
Oh, yes. And we have so many other amazing things in the store as well, just like the cap that Jim just put on. So take a look, and we are shipping out all of our items as soon as we get your orders. We're shipping them out the same day. Pam has been amazing in the office doing that each day. So we definitely thank her for that. But thank you, everyone. And thank you for joining us tonight, gentlemen. This was awesome. And we will definitely reach out to you if there are any more questions. But thank you for taking your time this evening.
Take care, everybody.
Thank you.
Right.
Hang in there.
Have a good one.